Okay, so we're going to start our next section. Dive right into some palpation. So we're going here into shoulder, elbow. I'm hoping that some of this actually is very helpful for you guys in regards to the cadaver dissection as well. So as we kind of think about where these structures are located, I'm hoping that some of our palpations and some of our review today will actually help you on Thursday as well. So let's start off with the scapula. I'm going to have our model come on over. Yeah, please, if you don't mind. And so the scapula structure, fairly easy to see. All right, so the idea here is we're going to try to identify all the kind of famous landmarks. There are obviously places where muscles attach. There are also places where we may, as we say, gain purchase, so we can kind of mobilize or move the scapula. I know that you guys have done a little bit of this in 508 in regards to kind of doing some scapular mobilization and things like that. So let's look at the scapula here and just kind of identify a couple things. So I'm going to have Dr. Ben lay on his right side, head up that end for me. Okay, so we can obviously go prone or sideline. I like sideline for this because it allows me to actually get underneath and kind of palpate all aspects of the scapula, and then it really carries over nicely into treatment as well. Okay, so I'm going to have you slide a little bit closer toward me. All right, so the way we're going to kind of do this, sorry, my hands are literally freezing. Would you mind taking this off? So when you guys are doing this, got to kind of take everything off, all right? Because we want to make sure that as you're palpating, it's much harder to palpate through close. So get up close and personal with your lab partners, especially in here today. It's freezing, so my hands are a little cold. Sorry about this. So what I'm going to do is I'm going to actually kind of place Dr. Ben in this position here. So go ahead and just relax your arm for me. So I'm in kind of a really good position to grab his scapula, right? So I'm just kind of appreciating, here's the scapula. So as you're going in here, you can really start anywhere you like. I sometimes kind of think about it as kind of the points of a clock. So we may start at 12 o'clock and kind of work our way around just so that we're not forgetting anything. And so as I'm kind of going through this, I might kind of begin to, first of all, identify this structure here, which is what? It's kind of on the upper corner. Yeah, superior angle, right? So superior angle here. So I might start at the superior angle, and then I can think about kind of following, that border, that spinal border or medial border of the scapula. So again, the best way of kind of doing this is kind of feeling that bone and kind of coming off the bone and then back onto the bone. So I can kind of work my way all the way down to the very inferior angle. So now I'm kind of on the inferior angle down in here, right? So I've identified inferior angle, superior angle, medial border, and then lateral border is a little more challenging because we have lats and we have the teres muscles, which we'll palpate in a little bit. So they're kind of located kind of in this area here. So you can kind of feel that muscle belly there, but if you really palpate kind of transversely across, you can kind of identify the lateral border of the scapula as well. Okay? What I can also do is once I find that superior border, I can kind of come across and I can try to identify the spine of the scapula. So again, the spine is coming this way. The best way of palpating a ridge of bone like that is to kind of come transversely across it. So if I can kind of identify that piece of bone and I kind of just come across it this way, I can identify that spinal, the spine of the scapula, which is right here. Okay. Now it's a little deceiving because the upper portion of the scapula is here, but it feels like it's ending here. This is actually the spine because this is the supraspinous fossa, and we're appreciative that we're looking at the supraspinatus muscle being in there. Right. So here's my spine. I've identified superior, inferior angle, medial border, lateral border, and kind of that spine coming across this way. So I'm always kind of just moving transversely across. The way that we confirm this, identification is fairly straightforward. The way we confirm it is really we just kind of move it, right? So we try to move that scapula. And again, it's kind of like a good early, first kind of pass at looking at passive range of motion or active assisted range of motion of the scapulothoracic joint. Okay? This is an important joint for overall shoulder mobility. We talk about the scapulohumeral rhythm and the arc that we circumscribe as we raise the arm, and we can appreciate that the glenohumeral joint gives us a fair amount of that motion, but the scapulothoracic has to move as well. So a lot of times in cases where we have limited motion, sometimes that's coming from limited scapulothoracic mobility. So one way that I like to kind of work on this a little bit is I'll kind of take my hand and put it kind of at the anterior aspect of the humerus here. And as I kind of pull back, a lot of times I'm able to kind of get underneath that medial border of the scapula pretty easily. So I can kind of work on that. Now the patient has to often relax, so if they're tense at all, it's really hard to get underneath that. But I'll kind of move around, and then I can kind of get actually underneath that medial aspect of the medial border of the scapula and under the inferior angle. So I'm kind of on that right here. So I might think about kind of moving it into a little bit of maybe, protraction here. I might move it into retraction, or I might call this a lateral glide or a medial glide. I might think about taking this whole scapula and moving it into elevation, moving it into depression, right? So I can kind of move this. So my conformation is really just kind of working through and playing with all the different planes of motion. So I can kind of look at it going up and down. I can go medial lateral glide. I also know that the scapula is going to upwardly rotate, right? So upward rotation is basically when this inferior angle is going to come laterally. So this is an upward rotation, so I can kind of work on that. I can work on kind of returning using downward rotation. So I'm kind of thinking about all the different planes: upward and downward rotation, elevation, depression, medial glide, lateral glide, one component of retraction, a component of protraction. And in some cases, I can kind of actually get under it. I can kind of get my fingers onto the anterior border of the scapula, which is an important location because there are two muscles that attach there as well. What two muscles are kind of hanging out at the anterior border? Subscapularis and the serratus actually inserts into that medial border on the anterior aspect of the scapula. So those muscles are important for us to kind of be aware of as well. All right, so this is kind of a nice way to begin to kind of start to work on getting your hands, on that scapula and kind of feeling how that moves. One way also that sometimes works is having them put their arm behind the rack. So as he does that, you can see that that really lifts that medial border up as well. So that's another strategy that we might use also. Sometimes I'll come in with their arm like that, assuming that their shoulder can handle that position. And that kind of makes it really nice because now I can do all kinds of things. I can lift that up and really kind of get that scapula moving in a couple different directions. So that works really well. So that's the scapula, pretty straightforward. Now once we find the scapula, it's not a hard and not a challenge really to kind of find that acromion, because we know that the acromion is the most distal aspect of that scapula, so it attaches to the scapula. And really, if we follow that spine of the scapula after we found that, and we kind of come all the way lateral, we're going to eventually end up on the acromion, right? So we think of the acromion as kind of being the roof of the shoulder, we often call it. We can appreciate as we look at the acromion that sometimes it can be an issue for people because there's often not enough space underneath that acromion. So again, here's the spine of the scapula right here, so I'm kind of working my way, kind of going against it here, going all the way lateral, and then at the most lateral extent of that, we're going to feel posteriorly that posterior angle of the acromion. So that's pretty easy to palpate, it's pretty prominent. Obviously you're palpating through muscle, so the posterior deltoid is here, but we're kind of palpating through that. And often it's fairly easy to identify kind of that posterior angle of that acromion right there. You want to palpate the full extent, so you're coming along the lateral aspect, coming along the anterior aspect, getting a sense for how flat that bone is, kind of working through that. Okay? And then we are appreciative that we have a very important joint here, the AC joint, acromioclavicular joint. Okay? So as we're palpating this bone, to confirm, we could do some of the movements of the scapula that I was just showing you, so we can kind of feel that acromion moving along with the scapula. To differentiate it from the clavicles, we're going to kind of feel that distal third of the clavicle. It's going to be a little bump, and that bump is typically a little higher than the acromion, right? So here's the bump of the distal clavicle, and I'm going to come off that bump, boom, and I land onto the acromion, okay? And there's a little kind of gap between those two bones. So to differentiate acromion from distal clavicle, is we could do a couple other things. We could look at moving the shoulder a little bit. Sometimes works well for that. So I'm appreciative that as I'm kind of feeling all of these structures here, here's that posterior angle, so I'm feeling that scapula, posterior angle of the acromion. I feel that acromion. I have it right here, so I can kind of feel how flat it is on top. I feel the lateral edge, posterior angle, anterior edge, and I see this distal clavicle right here, a little bump, and I can feel that that's higher than the acromion. So I kind of feel that space right there. And to fully differentiate and to really confirm, I might kind of think about movement. Now, as I'm moving the humerus, what I'm expecting to happen is the clavicle will oftentimes rotate, and eventually, if I raise it high enough, will elevate. So what I'm really looking for is I'm on that distal clavicle and I'm kind of maybe coming in a little bit, and I'm just looking to feel clavicular movement. I'm trying to feel that clavicle moving. And I could do this supine, or I could do this sitting if I wanted to. And just kind of getting a sense of, there's movement of the clavicle, but the acromion, because I'm not going far enough, I'm not moving the scapula. So the scapula kind of stays pretty stationary. So that acromion really isn't moving all that much, but the clavicle is. So that just kind of allows us to differentiate which bone we're actually on. And you can really see it. I mean, with thin people, there's not a problem. It's pretty easy to see. Most of you guys will be able to see that on each other. So that's the acromion. That's an important area. So I spent a lot of time palpating the area around the acromion, mainly the subacromial space. So one of the important landmarks that we kind of really look at with individuals that come in with any sort of shoulder-related pain is looking at that subacromial space. And what we're appreciative of is that in a normal shoulder at rest with the arm at its side, okay, there is about 11 millimeters between the roof of the shoulder and the head of the humerus. So this skeleton has more subacromial space than we normally have. Okay, we're looking at it kind of being like this. We're talking about in a normal person, okay, normal shoulder, non-pathologic, there's about 1 centimeter of space between the acromion and the head of the humerus. Okay, when we elevate our arm, that space reduces to 4 millimeters, cuts it in half. Okay, and that's in a normal shoulder. That's somebody that's non-pathologic. So imagine now if I have a little arthritis in that AC joint, if I have some bone spurs on the inferior surface of the acromion, now I'm starting off maybe with 6, 7, 5 millimeters. And when I elevate, what's going to happen? Bam, bam, right? So if I had a dime for every patient who has subacromial impingement syndrome in regards to shoulder-related symptoms, it's a very, very common thing. And it's an issue of space. Now, that would be okay if there's nothing important that's running through here, but we know that what runs through here? Supraspinatus, right? So it's in a really, really bad position. Not only does the supraspinatus in a bad location in regards to space and very easily impinged upon, but it also, the supraspinatus tendon kind of goes here and then does a 90-degree angle down to the greater tuberosity. So that really kind of, acute angle, that right angle that it makes, renders that tendon at the place where it makes that angle really susceptible to poor blood supply. It's kind of like taking that tendon and wringing it out. You're kind of stretching it over that bone, so it has poor blood supply and it's in a bad position. So that guy is just, it's like job security for physical therapy right there. Okay? Thank you, Lord. Good work on that one. Right? So that's the acromion and the scapula. Let's go into clavicle. Let's do one more. Let's do clavicle since we're kind of in the neighborhood here. So let's have Dr. Bennett, let me have you sit up for me if you would, and facing the camera. So as we're looking at, so we identified the acromion, we identified the distal clavicle here. So what we're going to do simply now is just kind of palpate the full length of that bone. Again, like we've talked about in other areas, if we kind of say, please palpate the clavicle, you don't want to just kind of go, okay, there it is, right? But you really want to kind of get an appreciation of, okay, here's the AC joint, all right, I feel that. I'm going to kind of palpate, distally. I'm going to kind of move into the middle third. I'm going to kind of come anteriorly as it courses medially. And so we can appreciate that it's kind of this S-shaped bone. And it's S-shaped with the convexity in an anterior direction more medial, and in a posterior direction more lateral, okay? So again, we're talking medial clavicle here, lateral clavicle here. And that's often the term that's used versus proximal distal. We might say proximal distal. I think I even have in your note proximal distal. But a lot of times we'll say lateral third or medial third of the clavicle, something like that. This bone, as you know, is often injured. Tony Romo, for you Dallas Cowboy fans, right? Fractured his clavicle. And so, it's susceptible to that, typically with falls where people fall on their shoulder. Not typically with the arm outstretched, but with kind of on the lateral aspect of their shoulder. So one of two things can happen when that occurs. When Tony Romo went down, I thought for sure he separated his shoulder, which is an injury to the AC joint. So it's either that, if the force is great enough, you're going to actually potentially do that and actually fracture the clavicle. So what you want to do with palpation is you're going to palpate along the length of that. Again, kind of like the spine of the scapula, the best way of really palpating it is kind of going up and down across it. So you can kind of get a sense, of, okay, here's the superiormost aspect, here's the inferiormost aspect. Then you want to come all the way into that head where it kind of creates that, that joint with the sternoclavicular joint. okay, right into the sternum. So again, just like at the AC joint, you'll feel that bump, feel that drop off, and you'll kind of come onto the manubrium of the sternum. I want you to get a sense, as you guys are palpating this, though, how the clavicle moves during motion. So whether it's active motion or passive motion, just kind of like hang out on the clavicle and see what happens as you bring your partner either actively or passively through that range of motion. You'll see that the clavicle will do a couple things. Okay? And we're going to talk about this to a much greater extent in kinesiology next semester. But you'll see with elevation of the arm, the distal clavicle is going to actually go upward. It's going to move superiorly. Okay? The other thing you're going to see is the clavicle will rotate upwardly. So if we look at this anterior border as being our reference point, okay, that clavicle, as we elevate, is going to kind of rotate upward like this. Okay, so it kind of does this and does this, okay, with elevation. So kind of get a sense of that. See if you can kind of begin to feel that motion. Because the motion is occurring with the axis kind of at the SC joint, you're going to certainly feel those motions better distally, right? Because this is going to be moving to a greater extent than this will be moving. You'll feel glide at the SC joint, but you're going to feel actually that bone elevating and rotating a little bit better as you come more laterally here. So you get a sense of that. I routinely look at that because oftentimes when we're looking at a patient that's having shoulder-related issues, we forget about the AC and the SC joint. You know, we spend all of our time thinking about the glenohumeral joint. And so a lot of times I just want to get a read on, you know, kind of what is that clavicle doing? Is that responding and is that starting to roll and upwardly rotate as I'm moving that shoulder? If it's not, there may be an AC or an SC joint that needs to be mobilized as well in order to facilitate that overall motion. So it is an important motion to kind of consider and think about. Much more subtle than some of the other motions that we'll look at. So here's Dr. Ben. I can see his distal clavicle here, and I can see how it drops off. There's the AC joint right there. Individuals that have AC joint pathology, oftentimes it comes in the you know, it looks like arthritis, so it's arthritic in nature. A lot of times that gliding joint develops bone spurs, and sometimes people will be tender along there. So I just want to kind of start there, and then I'm just going to kind of come across. I can feel that posterior convexity, and I can see it and feel it coming anteriorly, so I can feel the full extent of that, superiorly and inferiorly. And I can feel and palpate as that comes into the SC joint. Did you injure this at all?
This one probably.
Oh,
It's most
okay.
like I think this one's stromal posterior.
Okay, this looks like more prominent. There's also like a, I want to say cultural, but not cultural. There's a, what's the word I'm looking for? Certain cultures have different shapes and positions of the clavicle, which is interesting. So I've done some reading, like the Scandinavian population, oftentimes they'll have clavicles that are a little bit more horizontal, whereas in America they tend to be a little bit more angled. So it's like odd that it's kind of one of those things where you'll find deviations based on your, not culture, but based on your ethnicity. That's the word. Okay, good, thank you. So palpate that, and then, you know, kind of just put your hand there. And again, you know, I often find it's better not to look. You know, so you'll find not much happening here. See if you can identify when that clavicle actually engages. And for Dr. Ben, it's right about here. That's when I start to feel it actually moving. It's very, very subtle. And then it'll kind of continue to move as you kind of go upward. So if you're getting a clavicle that's not engaging right away or engaging too soon, you may detect something that's going on in those other joints. Okay? So some of you, yeah, you're palpating on yourself first, and that's always a good way to do it initially. All right, so that's some of the bony framework of the shoulder. Scapula, acromion, and clavicle. Go ahead and give that a shot.